I have Nitin Barman here and my two fellows, Mahi and then Gurpreet.
Hi, guys.
And then we have Pablo, who is a chief tech. Will, who is a nurse here in this room. Then we have Christy. You can see her. And then Anna, who is another tech. So as you see how we are able to do all these complex cases, because these guys are well trained and they know exactly what to do. Just with my eyes and my finger movements, they know what they have to do. So case number 5 here is an 85-year-old male who actually presented to an outside hospital with non-QMI with a troponin up to 14. So multiple comorbidities, hypertension, hyperlipidemia, EF about 45%, history of heart failure. So he has had prior bypass surgery with right now the patent graft is only Lima. So if you see the angiogram, this is the right coronary artery. EF about 45%. EDP was normal.
24.
And
24.
24.
Lima to the LAD open.
Written there.
Yeah.
Yeah. So, I mean, CAT said EF 45, but ECHO said EF 25. So the only patent graft was Lima that was supplying the entire LAD and retrograde to the diagonal. So this is the left main to circumflex, dominant circumflex, calcified, angulated.
Diffuse, yes.
Does it almost look like it's totally occluded or with a very, very antegrade flow is really small and almost like a bridge collateral, no? What does everyone else think here on the anatomy? Quan?
Some of the haze from the calcium.
Yeah.
Let me give you another view.
I think it's a CTO with a lot of bridging collateral.
Okay, that's a better view. It shows the
and a lot of calcium
99%
too, right? Calcium.
antegrade flow there.
Yeah, heavy calcium. Then you have OM1. You see the bypass that was attached.
Yeah.
Then OM2 or LPL, whatever you want to call. The
Huge territory.
Is kind of calcific angulated circumflex. What is the first wire of choice? And this is where I think the guide wire aid is going to tell us what is the first wire of choice. And let's ask the panel how we would wire this case.
Yeah, let's start with Dr. Freeman. Dr. Freeman, you see a lot of non-STEMIs. Here's a case.
Well,
what would be your first wire of choice?
Yeah, the complicated part with the tortuosity is also the excessive calcium in the area. So you want, I might start with support and something like a whisper wire to get down distally and then switch out. But I'm assuming you're going to plan to roto that or use some type of atherectomy device through that proximal circ area.
Yeah, does anyone question the use of Impella here? Let's start with Bill Nicholson.
I think you've got a working Lima to the LAD, but you're going to rotoblade a large territory, and it's going to be a lot of rotoblading. You got a bad EF of 20-25% to start with. I think it's a very, very reasonable choice.
Dr. Mehta? Can you speak into the mic because we can't hear you?
Probably a run-through wire, then exchange it for a rota, probably starting with the 1.5 burr and expanding, I think, with the second burr.
Wow, I get scared with a 1.5 burr. I don't know. What do you all think? Like 1.25, 1.5? I don't know. It's very, very severe.
No, but I think let's go to I think wiring is very challenging in this case. That is, I think, the key in this.
We have your aid up there. It's showing us what we should be doing here. But Dr. O'Neill?
I think the most difficult part of this is getting the rotoblader wire down distally. I think that's going to be the biggest challenge.
Yeah.
You can wire
we can't.
Something, but actually getting the exchange is going to be quite.
We can't hear.
Yeah, Dr. O'Neill is saying that the most difficult and challenging part of this is getting your rotowire distal into exactly where you want to ablate. That's going to be difficult, even in the exchange, etc. So that's going to be really, really interesting to watch. So tell us, what's your plan, Dr. Kini?
So our plan is I have a fine cross, and I'm going to start with the fielder. This is what we have actually mentioned also in the app that you will start a case like this with a fielder. I mean, it is all depend. Everybody has to probably use a polymer jacketed wire to see if we can go through this angulated calcific vessel. And I just need to show you, this is how we did this case. So if you see here, fielder, same, what we say is twirling movements, and it's trying to go into the OM, which we knew. Now you pull back. We had a nice curve in the fielder, then rotate, and you get into the distal circ to the LPL. Like we mentioned, the next challenging part is, can we get the fine cross? So this is exactly, you see that?
Yep.
That calcium and the angle, the fine cross would not go down. So what you essentially do is you twirl, rotate like you want to do with a corset. Exactly the same movements you can see here. Get your guide in. Guide has to be advanced. Guide is, see that, trying to come out. Keep the guide engaged and keep doing, and now it went through.
You got it.
Yeah,
Nice.
then we exchange it to the rotor wire. Now, question is the same. If the fine cross had gone easily, we would have used a 1.5 burr. Knowing that it was so challenging to have fine cross across the angulated circumflex, we have downgraded to 1.25 burr. And we are ready to do the rotor now.
So, Dr. O'Neill, what do you think?
Going
of that?
1.25,
That was pretty
1.5.
good, huh?
1.25.
Slick.
Yeah, that's fantastic. We use the.
It's talking about 1.5. I'll go with the 1 bar stage available.
Go
So the question is the same. If fielder would not have crossed, what would be the next wire of choice? You know, there is pilot wires, which you can use because they have a little bit extra tip load, or miracle wires, which starts with a 3/0, 6/0. It's all what you're comfortable with. I called for a miracle ready only because with miracle you are able to make a curve and get into the circumflex. Now Gaia family, which has come with the Gaia next, which are very good wires, but they come with a pre-made curve and not easy to make an extra curve on those wires. And if you make an extra curve, it's not able to navigate well.
So Dr. O'Neill had a
This is
point to
we are
make,
in the
Dr.
proximal,
Kinney. 1 second. Dr. O'Neill?
I found the Turnpike LP probably the most crossable of the micro catheters.
Why can't we hear it well?
We can't hear many of the people from the
Well, that's,
podium. Dr.
guys, can you fix these mics? I don't know why they're not
yeah.
hearing it.
2.5
They can hear me, but they're not hearing the panel, and that's not very helpful. So, yeah, so the Turnpike is what Dr. Turnpike LP is what Dr. O'Neill was talking about as one of the
Yes.
go-to. Okay, so let's see how you're going to do this. This is also could get stuck in the calcium, especially the 1.25 burr, right? So let's
A
see.
little more new. Yeah. And you know that one of the reasons for impella here is also is that very high chance of perforation in this case. Very high chance. So at least will allow us to do a work, gutter, and so forth.
Speed it up a little bit.
So that's why we said that it may be, you know, some people may feel impella may be a little overkill, but just to make a procedure a little safer.
There's some
Yeah.
problem.
24 was LVD.
Yeah, but that's okay. Yeah.
No, they're
So
going.
little high
They're not
ADP
stuck.
also, but more important. Yeah.
So sound sounds a little.
This is a crucial point.
We hear the screeches of the machine slowing down with this spur.
Yep. Yeah.
Changing wire position too is important.
What Nitin is saying, he is changing the wire position.
Yeah, just to
So
make
if you
it
see
not
here, I
be
don't know if
so
you can see my
curved.
hands. Yeah, you have a circumflex with a wire like this, and we are going with a rotor burr. You see here, this angle that we have created can cut the rotor wire. So what he's trying to do, if you see here, brake release, and he's trying to move the rotor wire a little bit forward, backward.
Changing the position that stresses.
Any question should we
Okay.
have
Right.
used?
To de-stress the
Yeah.
The angle, basically that wire bias and
Yeah.
one side so that it is not cutting the wire. Yeah. Which has happened, and of course the burr is stuck. Yeah.
Yep. We see that it went through.
Yeah. Actually, some of the tough cases, I'm working with the Boston Scientific to make even a 1 over. I think in this kind of case, even 1.25 may be too big. But you need that. You need, and then of course you can always upgrade it.
Okay.
Now you're full
Breather for the patient and breather for the operator.
Yeah, for sure. These are really, I mean, you're really happy that you have the Impella in place, guys. I don't know that anyone is questioning that choice. Anyone on the panel would do this without support? There is a Peyton Lima.
I think I should. I don't want to go there.
No one.
The LV function is
Might have to
increased, right?
proximal a little more, I think, here. I just
No,
pulled
it's
it.
okay.
LV is about 40 to 45%, but he presented with heart failure. So diastolic dysfunction. Today also the EDP was 24. So it does have a component, both systolic and diastolic, but truly it's not a classical over 35% EF.
Okay, ready?
Yep. But I will say that if once available, and this is precisely, this Impella is approved for this kind of a protection. So two things. One, complication, and secondly, in a long calcific lesion, decrease the slow flow. So that is the key. It will decrease the overall chance of slow flow in this very complex case.
Okay.
I've got to say that I don't really like the 125 per. If you take a look at the angle, it's a very shallow angle. And the 1.5 has a steep
Kind of the
angle.
LPL.
He actually cuts better. I think the 125 doesn't really cut very well.
Now use 1.5.
I hardly ever
Now
use
1.5.
Is there a few there? We got to redirect the wire.
And that's very easy to trap
It's
inside
okay.
the
Leave it.
bird.
Leave it. I don't do anything.
Have to-
Okay, 1 fiber. You want? Assist? It was
Right.
not easy.
Stepping
go
up
down.
to the
I don't
next
know, I'm a little
level.
worried
What do
about
you
the
think, guys?
Tortuosity to me, I think
I think you go
It's already we have,
1.5.
see that? The vessel is opened up, cut.
Okay.
there's a clear
I think we
gutter.
will just balloon.
The question is, the burr wise, you're done 1.25. Do you upgrade it, or you try to see your balloon can open up the lesion, then you don't need to upgrade it? I think that's reasonable. That's what Anu is feeling, that let's put a wire, let's put your balloon, and if it doesn't expand, you have a rotor wire there, you upgrade to 1.5. I don't think we will go to 1.75 here. That's maybe 1.5.
Roxana, can you see the proximal circ wire bias and looks
Yeah,
like
no,
you
of
have done a
course, we
good
see
job
it
with the
very well.
1.25
I mean,
yeah.
there's a lot of wire
Yeah,
bias.
So that's why I'm.
You're
I
not
don't
too
want to
happy
go with
about
1.5.
going. I mean, it's good if you could get away with the balloon, that would be great. But I don't know
Yeah.
how much ablation you got done with that small burr. So I think that's the question.
But remember, very important, what I say in the angulated lesion, and this question comes up all the time. You may not have done the ablation, which is point you are making. The key is, but if you cut the interelastic lamina, so you have really had disrupted the architecture of the vessel. So goal is your balloon should expand it. You're right. We have not done much in the ablation, but we have cut because of eccentricity, the interelastic lamina. So that as long as your balloon expands, your mission accomplished, kind of that. Now your stent will expand. So that's the reason. You're right. If we just go by the principle of the debulking or the plaque modification, this is not the right approach. Now many people are very much against 1.25 bar. I can tell you. One of the reasons they say it gets stuck, and so again, we probably do the highest number of rotablation in the world, about 60 per month. Our burr, if ever stuck, it was never 1.25. Either 1.5 or above in unexpanded stent or otherwise. So key is, as long as you did the technique what Anu did, slow movement, advancement, and so we have never stuck in. Yeah, I know a lot of people, this is a common, I would not say common myth, because there have been some cases, people have spoken that 1.25 bar is the traps the most, bar is stuck, and so, but I think it may be just a little bit a technique point of view also. So because I can tell you the data at our own Sinai, we do have some bar stuck, but it is, if we take 1.25 or 1.5 or 1.75, 80% was 1.5, about 15, 16 or 18% will be 1.75, 1 or 2% will be 1.25.
See, I think the other thing to consider is doing a shockwave right now, because you've created a pilot channel already. And I think if you put a shockwave in, then you can go directly to stenting and you have full expansion.
But only, Bill, you will require multiple shockwave here, very long lesion. But yeah, that's a very good strategy. going rather than going to the second burr, and that is what we are going to do. We have written very calcific lesion algorithms 3 times already, and now getting some more experience with the shock wave, we are going to show, we are going to put it down that what is the best strategy where the shock wave should be used, and so IVL in combination or alone. And basically, yes, rather than going to the second burr, using a shock wave is absolutely great choice.
Looks pretty
Yeah,
good
that would have been
expansion
an
lines,
interesting next step, but it looks like you didn't need it. I mean, the balloon seems
Look at the
nice.
balloon expanded with a 1.25 bar.
Yeah, it's
Yep.
amazing.
And this is the example we say, leave the rota wire there. So if you need to upgrade the bar, you are not worried about.
I think we have to go with the short recess.
No, but first open the ostium a little more.
We also burred into the distal circuit, not the.
Yeah, here. Just open this way first. Yeah, just to here, high pressure. And then you're going to decrease the profile of this balloon in the guide. Let's bring back the guide. So what happened is where you want to rewrap the balloon, come in the guide, go up high pressure. So what happened is, in the guide, you go high pressure. So basically, now your blood pressure will become flat, negative. So basically, you are done what company does. Remember, all balloons come with the additional attachment.
2512 balloon.
Okay.
I think we didn't rota in there.
But
It's
point
still-
is your wire, we have not done the work
The
in that.
wire is not in the same
Into the
plane
OM.
as the other wire,
Yeah,
so
that's
it's
what I'm
it's
saying.
possible that, you're,
Yeah,
because you
see that
rotated
OM,
down the
ostium
other
OM is
branch.
little involved, yeah.
you rotated in the other branch, so.
Into the distal surf. We
Yeah.
went into the
This is
distal
sir. Yeah,
surf.
so we are going to use a 2.5 new balloon,
12, short. Yeah.
2.5 12, okay?
Very nice.
You want to see the
So
picture
will
yet
you
or no?
image
Not yet,
this,
not yet.
Dr.
I want to
Kini,
balloon
at
everything.
the end? Will you do IVUS
No.
at the end?
No.
Okay.
Yeah, okay, no. We can do this case, easily come out. Okay, let's go here. Despite 1.25 balloon.
Yeah, we need to go back to that.
Have a compliant balloon.
Compliant.
Okay, now,
Get a 2 compliant balloon.
212 compliant.
do you want to do that or go with the guideliner?
No, 2
Godzilla.
compliant, 2
Okay.
compliant balloon. We are going to go with a 2 compliant balloon.
So we're hearing, you can go to the guideliner too, to extend the
Yep,
guide
that-
and help
yeah.
deliver that
Bigger picture
balloon,
now.
but
Yeah.
they feel like with a non-compliant, they can get to it.
2 or 12?
Well,
Or you can
ostium,
just-
that OM, there was a disease also,
Yeah,
if you
I
take.
think so,
Not in
and
the
we
one.
never rotoed down there,
No, I
You
mean
rotoed the
OM,
other way.
It's in that LPL now. No, my wire is in the LPL now, not in the
Yeah.
OM.
Yeah,
And with the rotabar, we did go distal to the OM.
But not to.
One.
Wire
Yeah.
connect?
Huh?
Well, that was from the 406.
Okay, so we're going to the LPL.
If this doesn't cross, then we're gonna have to rewire with the,
Hmm.
yeah.
An LPL lesion.
Okay, Godzilla.
Yeah,
Okay, let's get the Godzilla. Do you take one wire out anyway then?
we can leave too. Okay, go up here.
I think it'll be able to
Yeah, now
nose
it
through
will
there,
go,
yeah.
yeah, down. Okay, go up there.
My question is, what if you direct back your wire into the main distal circumflex?
I tried,
And
would
then
not
try.
go.
Eh?
I tried, initially did not go. I had to
Okay.
maybe change the,
Got
okay, let's start, me try now.
Guys,
Get the Godzilla ready?
Take it.
You can do it on both wires still here.
Yeah.
Now, actually, the Roxana asked me, and this is for our
another
audience, that we are not doing FFR, IFR in these cases. But these cases are so long subtotal.
Sorry.
Many of these wires will not be able to advance. But yeah, in a moderate lesion, and that is what the part of, is the whole case of the theme of the symposium. Our cases are so complex, these, if before making a decision, maybe to the branch or something that you may decide. But these cases, yeah, good, wire went in now.
Now give me.
Yeah. So key is that not appropriate, but we want to do some just say.
No, of course not in those significant lesions, but also I think the role of imaging, we find so much more when we do image, but you guys are, everybody has their practice and everyone is very respectful of the great results you all have, but we wanted to make sure we mention the role of imaging and guiding intervention. And we will do that, I'm sure, when it's indicated FFR, IFR. So now you put the wire into the exact place where you did
where it was supposed to be. Yeah. So now balloon will go.
Now balloon
and
should
the
go.
other question is remove the rotor wire out. And the second question is just to say that FFR, or sorry, imaging, we do physiological, IFR and FFR makes about 62% of our intervention. So, the national number is about 32 now. And we are 62%. So that is one of the quality parameter which we have in our lab.
So the audience is asking, Dr. Sharma, I have the questions from the audience. They're asking, if there's no dissection, why would you not go to a larger burr to do better ablation? I think it's a good question.
No, there is no. We showed you from the first time.
But there is a little dissection.
Yeah,
there is a dissection.
And there's wire bias with the dissection. When you already have a wire bias, and then you want to go to a bigger burr, then there's risk of perforation.
Yeah. And let's but the audience, they ask us, let's see. Maybe it's by the virtual versus what? We can just show 1 second. Here. Yeah, here. See that? Exactly where it originates.
There is definitely a dissection there. I wouldn't do that.
Exactly. Yeah, proximally. Yeah.
Gutter, yes.
Okay.
The patient characteristics too, extreme elderly.
We are ready with the 1.5 burr.
Yeah.
And here you are now with both the guideliner and the wire in the right position.
What balloon is that now?
This is 2 compliant again.
Okay.
Go up.
Go.
Maybe you could roto past
Once they
the
dilate,
dissection.
then we go to other room. Yeah. Yeah, that's another thing. No, that's okay. A lot of people have done. This is a 6-strength guy. The rotor wire will not go.
Oh, no, here you go.
I mean, the burr will
It went through now.
Yeah, went in now.
We may, not even that, we may rupture.
Yeah. 112. Want to send in or?
So
It seems like that needed a little bit of atherectomy as well.
Yeah.
No, the way you get the balloon down is you dilate in the proximal vessel, and then you get your Godzilla down there, and once you have your Godzilla in the proximal vessel, you can go distal. Now it's going good. Now you want to go 3-0 high pressure everywhere, up and down.
So I think in this case, if you're okay, we can just see the picture, show it. If it looks good, we can go to
if you show us, we can go back to the other
ready.
room to see how you did, and maybe to the third case, because we only
No,
have
that one
11
is
minutes.
simple. Our case, no, I know. We'll finish it that way. My case was simple. We dilated with a 4-0, fantastic. It's like lumen, probably 9 millimeters square.
Excellent. Yeah, this is
It's
a
a
much
gutter, that's
larger
okay.
dissection now. So you'll be
I think
covering
you need to put a
this.
stand there.
Yeah, you'll need
Just put a
long
stent.
Yeah, this stand
now
now.
high pressure.
No, right now stand.
Okay, good. Now we are going to cover the OM.
Yep. Right now.
So we will start 3-0.
Okay.
What stent do you want? 3-0-38?
Yeah. 3-0-38 Zions.
Do you want to stent into the LPL or the
Zions?
No, they're not touching.
Okay. We're gonna.
After the OM, wherever we dilated, from there, come up to the left
Gotcha.
main.
Okay.
Yeah, it's a pretty big dissection. So, okay, so we're gonna go to your other room, Dr. Sharma. What are we doing?
No, but I think we want this stand to be there, and then we go.
Okay,
But I
we'll
think,
see.
Roxana, one important point, I think in this case, is that why we did not go to a larger bar. I hope we made that very clear.
Yeah, I think,
Once
you
we
know,
did
we saw
1.25
your
bar.
dissection, but then the other question was, when the balloon wasn't going, could you have come in with the rotor burr past the dissection and just do a little bit of a distal ablation for, but it looks like you were able to finally open it with the balloon, and now you're going to stent it and it should come out okay. I think that was
But
the
those
other
are
question.
all valid points. I know that is exactly the point we need to do and show. And I'm so sorry that we got a little distracted, abbreviated our cases this morning. And again, we learned from all this. And that is what Anu always wanted, do only 2 cases per hour. So next year we are going to change, Roxana will just make 2 cases rather than 3. Because
I
we
agree.
need to go through this step by step.
Yeah, I think
These
everyone
techniques
wants
are
the
ones
step
people
by
need to
step.
know. Yeah. Yeah, exactly. And they want to see the case in entirety. That is the key.
Yeah, watching this struggle.
So we just have 2 cases. Yeah.
So,
Which is
next
okay.
step, Antonio, what you're happy with this? With this, you see the guideliner. What would you have done? Anything different?
Okay, now what I would have done?
She's
No,
still
I
having
think
a hard time.
I think
Too
so
high
far
pressure,
I would
yeah.
have done the same. As was mentioned, maybe after the 1.5, 1.25, I almost always go with a 1.5. But the result is
High
good.
pressure.
I think in this lesion, the dissection is expected.
Yeah,
Substantial.
It's a big dissection, but it's not a malignant.
not a big deal.
No, it's okay.
I don't know. I don't think I would have gone up to bigger burr. I think the artery was so angulated and tortuous that you might have really kind of filleted through it and caused a massive perf. So
Yeah.
I think they made the right decision to
it's the
stop
12 lane.
with the smaller burr.
Just wanna
I
make
would
sure.
have started with a 1.5 to begin, but I don't think I would have upsized after you created that huge dissection.
Would you ask them to go to a larger balloon now to do a little bit of a better dilatation? They're having some difficulty delivering the stent.
No, but that's
3
exactly
O's
being
now.
done now. That's what the balloon they are doing it now. Absolutely, Roxana.
Can the carcilla go a
What
little
balloon
bit
is
deeper?
inside?
That's the same.
The
Dr.
carcilla,
Kwan?
can it
It's a
go a little bit
2.5.
deep? Can the carcilla go a little bit deeper?
Oh yeah, she was putting it pretty
Yeah.
deep with
Yeah.
the Godzilla.
Yeah.
I saw that.
No, we'll go it now. More.
Come back a little bit.
So
Advanced, yeah. That's
now
it.
there,
Yeah.
now deeper. That's it.
Let's do that spot there. You want to do that spot? Or no?
No, we did it, no,
I think you got to come back a little bit with the.
Get the mouth.
balloon. Let's just do it while we're there. You can put it back in a second. Yeah.
I think we did. Again, I don't know. It's in a good spot.
Okay.
We'll never get it. Okay, get the stent again.
That's ready.
That's a really
The
great
Godzilla is
technique.
quite
Same.
down. Yes, go ahead, Dr. O'Neill.
Yeah,
go
that's
ahead.
a really great technique to use the balloon as an anchor, and you pull the Godzilla all the way down there, and then that way you can really get it deep throated into for the stent placement.
That's exactly, and I think she even dilated a little bit better.
Yep.
Okay.
And
So
same,
you see,
that once you
everybody
have your
could see-
Godzilla, make sure very little injection. Yeah.
Yeah, that's a
Everybody
really important
sees
point.
that the Godzilla is all the way down. You see it, the tip of it. It's really literally, as I'm showing you.
Can somebody show the hemodynamics?
Yeah.
Show
And
the
the
hemodynamics,
hemodynamics
please.
are totally
So just to say-
stable
yeah.
with
Yeah, but we'll have
no.
this
What
is the Godzilla.
the Godzilla, this is what it does. So you have to be very
Yeah.
fast. Deliver the stent, pull the Godzilla out so that you make sure then
And very
You
slow.
confirm
yeah,
From
we
the
see
position.
we see that.
How the Impala working well?
The
yeah,
Impala.
Impella is good. I'm going to pull the Godzilla
The Impala
back
is
now.
working.
Impella is our
Godzilla
friend.
comes back.
Impella
Stent
is
is
our friend.
delivered.
Good.
Impella
Look at
is our
that.
friend.
Some guy.
And you see the blood pressure coming right up, right here.
Good,
Very
right?
long
Yeah,
stent.
I think
Oh my
right there.
God.
Yeah.
Good,
Yeah.
go.
So all kinds of tools.
Now-
Now your guide is very deep. Yeah.
14th.
You just brought it back.
No, I pulled back.
Back that.
Yep.
Yep.
This, what size is
If you
this?
need, if you need a short stent, this is a 3038.
Number
If you
325
need,
or
we will
35
put
high
a
pressure?
35 into the left main and then we'll post dilate the left main. Yeah.
I feel like this is a larger vessel than a
Yeah,
3.0.
yeah,
I think you're going to
30.
post dilate with a
3.0,
larger
30.
balloon.
3030.
Maybe 3.5, I will see.
Okay. You want to decide if you need a
Yeah,
stent?
let's take a
Okay,
picture.
ready?
Yeah, I need one. I don't know.
Okay.
The moment of truth.
Yeah.
All right.
Wow.
I think
Very
rest
good.
become a little
Excellent.
simpler. We'll be ready other side.
Well,
I'm,
we will put a 12 millimeter 3.5 coming into the left main, post
Okay,
dilate
take this
everything. Any questions for us before you go to next?
I still worry a little bit about the outflow of the stent. Anybody else feel good about this? Everybody feels good? I think it looks great. I mean, it's tremendous.
Step
Any-
down.
But
This is a step down.
we are very reluctant to place these long stents. They restenose. If you look at these long stents after 3 or 4
Yeah, the
years,
DEB is low. Yeah.
they always restenose.
Dr. Mehta?
Yeah, Roxana, I think the distal to the stent, I think will be all right. To me, the whole teaching part of this whole case was the use of Impella. Look, the traditional thinking was EF is 40-45%, you could probably get away. But a lot of these maneuver, including the deep throating with the Guidezilla as well as the use of rotablator, I think the Impella made it all possible.
I think it gives it a very clear-cut way. Dr. Nicholson, any comments from you?
I think it's very nicely done. A lot of nice techniques demonstrated. I think it's a great case. Congratulations.
Okay. So
Thank you. You can go to
looks like you're putting another stent. This one is a 12 or
yeah, proximally we need another stent.
Okay, can we
Into the
see the
left.
fluoro, please, instead of thank you. Again, need the Guidezilla. Still
Now,
need the
see that?
Guidezilla.
Yeah, exactly. This is
It's
short,
amazing.
forgive me. Short?
Do you guys worry when the stent is there, you bring in
You
a
can come back, like,
Guidezilla?
8,
Aren't
10
you
more
worried
millimeters.
that
You're
like
completely
you
overwhelmed
could
right now. Yeah.
accordion the stent?
Sometimes, right?
No?
Want to send it?
Yeah, the interesting point, Roxana, you see,
sometimes it causes
I advanced
deformation.
It went very easily. If the Guidezilla would not have gone easily, I will not push. Yes, there can be stent accordion, exactly what you mentioned. In that case, I have to go back with the balloon, distal to where
Dilate
it is,
better.
and then
Yeah.
over the balloon only I will, advance.
Yeah.
Okay? So now we are going to confirm.
Yeah, pull back many millimeters.
Yeah. We are
6
too deep.
millimeters back.
This is going to look
Right?
great.
Okay.
Just do it
Come
on.
die. Good. Go.
Nice.
So we'll post dilate the proximal, I think, left main with 4O.
Yeah, I think you can use this balloon and
dilate
dilate
more.
a little bit down into that distal stent too. A
Overlap
little.
with it.
I
Yes,
still think
yes,
you have
we'll do
room
that.
in the proximal portion of that other stent.
The proc circ, put in the LPL. Those are the same.
Okay,
We
now
have
I
2
pull
minutes
back.
left. We're staying with you, Dr. Kini.
LPL, exact same.
No, you have to go to other room.
Okay, because we only have
Room
2
3, they're
minutes.
ready with the OCT and
Let's go.
bifurcation.
61-year-old gentleman, he's diabetic, he's hypertensive, he's smoking, and the first stent was deployed in 2010 in the proc circ. There you see a trifurcation. Second stent was deployed in 2012, and the third stent in 2013. He did well until recently when he developed symptoms, and I'll show you what he has. Okay, now I'll show you. This is the LV-gram is good. The RCA has some disease in the proximal, it's not that bad. And then we have this troublemaker down here. I have lost a distal circ before, and here, this is just AP projection showing the trouble. So we'll OCT first. Go ahead and show the OCT. Please, OCT.
And there are 3 layers of stents there.
Yeah, I
So you
can
guys
see
see the-
that you guys left those bifurcations. They didn't do anything to the side branches, but there's at least 2 layers of stent there, isn't there? Yeah.
So there are 3 stents overlapping in the distal segment. So you see the right now you see the neointimal hyperplasia there,
1, 2, 3.
and then we start seeing the double layer. You guys see in there?
Yeah.
And then there is an area where you have a nodule, an ISR with a big nodule of neointimal hyperplasia. Just go proximal and then you see the calcium. So over here is neoatherosclerosis, and that's calcium. See the refrigency is very direct. You can see behind. So that's not lipid. If it was lipid, you wouldn't see anything behind. So here is a lot of calcium in this ISR. A 360-degree calcium there with the double layer, and more proximally you see neointima and a little bit more severe neointima hyperplasia. So we have trouble with this case.
Calcific ISR. Calcific ISR is what you're showing us.
Calcific ISR, exactly, in one single case.
And ISR form, other question is, why not it's a calcific neoatherosclerosis?
Correct. That's what it is.
Yeah,
That's what it is.
neoatherosclerosis developed and now it's a very calcified.
That's
The
exactly
question
what it is.
That, as you know, multi-layer, we try to do, our goal will be to do IVBT. These are the cases we don't have drug-coated balloon, and we'll hear out from Colombo. Look like Antonio loves the drug-coated balloon now. And maybe once it comes, quite a bit, but here we have only IVBT. So what we are doing now, bar
2.0.
It's a 2O bar. 7 French radial.
Yeah, 7 French radial.
If somebody wants to know that radial, we are putting a 7 French.
And it's a 2-0 burr, right? It's a large burr.
Yeah. Yeah.
Yeah.
Give little
Give the atropine.
I think a question that needs to be explored is will drug-coated balloon work on calcific lesions? Because it's like putting a cream on a piece of stone.
Yeah.
I don't think the cream
You still
will be
have to
absorbed.
do atherectomy and then put the
We're
balloon.
gonna restart now. We have a heart rate again.
Continue, yeah.
And the key here is not to do the strut, the rota strut.
Yeah. It'll take us some time.
This is a problem.
Yeah. Don't get it
Too excited, yeah.
It will take some time. And see, I keep changing the wire position.
Yeah. And I see you don't have a pacemaker here.
We understand?
Yeah, good.
Yeah.
Yeah, so key is very simple. Radial, we try to avoid pacemaker. You give aminophylline 300 milligram and atropine 0.6 to 1 milligram. Pulse rate is good. We start with a 2-0, maybe a little more aggressive. We'll see few seconds, 2 more runs, not. We'll downsize to 1.75.
I think aminophylline is excellent. We stop using pacemaker.
Oh, you're using
Aminophylline
aminophylline.
infusion.
All right.
Excellent. We stop having perforations of the right ventricle.
Okay.
Yeah.
But what I'm seeing is you have to be patient here because there's calcium. It's a lot of disease. You see some decel. You want to go slow and steady, which is what they're doing.
Why 2-0 burps in the beginning? Can we do a 1-5 burp and upsize?
Yeah, I think that's what Dr. Sharma was talking about. Maybe 175 and then go to a 225 or 2-0. But
yeah, because human was so good. That was the only reason, yeah. Yeah. Good. Good.
Okay, we're done.
Okay, done.
Okay.
Now what wire in this? And we have the IVBT team.
Yeah, we're gonna call the IVBT team.
No, they're here.
So Ron Waxman is here. I'd love to get him at the at the mic, Ron. IVBT, it's you are using it in your center. What do you think here? I mean, you wouldn't put in another layer. We don't have drug-coated balloons.
Why?
Can we open Dr. Waxman's Ron Waxman's microphone, please? Is it working?
1, 2, 3.
Yeah,
No,
no.
it does. No, we think that 1 layer of ISR is enough. Brachytherapy is still going to save you another stent and probably will get you the best result. So I think that all those cases that you showed today, even the underexpanded one, probably it's better to put brachytherapy instead of another stent. The other comment that I had, if you have 2 layers of stent, this is going to be much more difficult to open an underexpanded stent.
Yeah.
But brachytherapy to me, for DS restenosis is the first
So
line.
how many on this panel are using brachytherapy for these ISR cases until we get drug-coated balloons? Dr. O'Neill? Yes? And are you impressed with your results or?
It's too early to tell. I mean, the problem was that we've done it for 30 years, and the problem is 2 or 3 years you get late effects that you're not aware of. But at least in the first couple of years, it seems to work.
Yeah. So Dr. Colombo doesn't need it because he has drug-coated balloons.
We don't have brachytherapy in Europe.
Yeah, no brachytherapy in
It's not
Europe.
available.
Yeah,
Dr. Nicholson?
I think I would echo the sentiments that Dr. O'Neill said. I think early on it looks good, but worry about the late-term effects.
Yeah. All right.
Give me the fielder one.
So now here you are with the balloon, and you will be generous with the balloon, right? What size is this? 3.5?
One of the things the trouble we have with this case is that we always lose that distal circ. So if I balloon too fast, it's gonna go down, and so I need to wire the distal circ.
Yeah, distal circ. Remember what has happened? Patient had a few interventions before, and the distal circ is knocked out when you dilate the main vessel. So we have not done that yet, and now we are going to do wire into the distal circumflex.
Yep.
Yeah.
We still open?
Yeah, open.
It's still open, but it's on a thread.
Hanging by a thread. Yeah.
So strategy point of view, and I know that you need to start your the debate. If you want to do, I mean, we had just shown another case, and only question is if the audience wants to see IVPT, how would they see it? Yeah.
Let's just see how that goes, and then
Okay.
Little thing there.
Yeah. Will be very angulated.
we really don't want to lose too much time for lunch, and the exhibits, Dr. Sharma.
So I think that you start your debate.
Yeah,
that will be best way.
Yeah.
Before start the debate,
Before
and we'll
we
show
go
you
to
the end of
lunch,
the
where you show us what you did, and we'll put on the side where if you can put the fluoro on the side where the factoids are, then we're going to go to our debate. And we thank you all, guys, for being here. And thank you.